Pat, thanks for the introduction. And actually, it was a great segue, the talk that Dr. Snowden is going to give with regard to post-COVID in pediatrics, because although I know we've talked about this a fair amount, I'd like to kind of revisit it with a paper that just recently appeared out in the press, and just again, re-emphasize this condition and the fact that I think that many people just simply don't take this into their calculus when they're doing their risk acceptance and risk mitigation. And I hear so often from folks that, hey, you know, I'm young, I'm healthy, I don't have risk factors, I'm not going to get seriously ill or die from this illness. And, you know, I can kind of understand that rationale to some extent, but I don't hear any of them saying, oh, and I'm worried about, you know, post-COVID conditions, and maybe that's a reason why I shouldn't be crowding into the bars, or maybe that's the reason I should go and get a vaccine. So I just want to reemphasize this and the fact that we really need to be putting this into our messaging with regard to risk mitigation strategies, and also in our conversations with patients regarding why they should get vaccinated and boosted. So this is the paper that came out about 10 days ago in the MMWR. I think it has some advantages and some real strengths that I will try to emphasize, but I also think that there's some limitations on this study. It's a retrospective matched case control cohort study using the Cerner real world data set. And I think that's probably the biggest strength of this, is that it just shows the utility of using some of these EMRs and the fact that we can now gather data relatively easily on tens of millions of people. So the Cerner data set involves over 60 million Americans, 110 sites, all 50 states. And what they did in this study is they looked at about 350,000 COVID patients. They matched them 1 per 5 controls for every 1 case, in order to ascertain the occurrence of late COVID symptoms. And as you guys know, late COVID goes by a whole bunch of different names: long hauler syndrome, long COVID, chronic COVID, post-acute sequelae of COVID, whatever. We're going to call that post-COVID for the purposes of this discussion. So they looked at these cases matched with the controls for 26 different clinical conditions that have previously in the literature been attributed to the post-COVID syndrome. And they examined the onset of any one of these 26 clinical conditions in the 30 days to 1 year after the incident occurrence. So after they had COVID, they looked at this period of time along with their control patients. The immediate limitation that you see is that although this is over a long time period, it stopped pretty much at the end of 2021, so does not include Omicron survivors or the more recent subvariants of Omicron. In the table that you can see on this slide, they divided the patients up into those who were 65 and older and those who were less than 65, but still of adult age. And so again, comes back to the comment that in pediatrics, we also see this condition, but that is not shown in this study. And then you can see at the bottom of the row, the total number of case patients and the percentage that developed any one of these 26 conditions. And so because these conditions are so broad, so for instance, you know, malaise, fatigue, mood disorders, sleep disorders, it would not be unusual for people who were in the control group to develop some of these conditions and to present to their clinicians. You can see that 16% of them did here at the bottom of the slide, compared, however, to over twice as many, 38% of the case patients. So the overall percentage difference is about 22%. And the overall conclusion is that if you're younger, you have a 1 in 5 chance of developing a post-COVID condition in the 30 days to 1 year after your COVID diagnosis. And if you are older, it's actually even more common, 1 in 4. Now, this slide is a figure again from the publication that shows all the different conditions that were looked for. And you can see that they are split up into the various areas of concern, so cardiovascular, pulmonary, renal, onward down the slide. They're broken up into the age groups. So the dark circles are the greater than 65, the lighter circles are the less than 65. And these are the risk ratios for developing any of these conditions during the observation period. The horizontal line, vertical, is at 1. So you can, I think, immediately appreciate that the vast majority of these conditions are to the right of that line. And you can see that the confidence interval, for the most part, doesn't cross the line, meaning that they are statistically significantly increased risk of developing these conditions in the COVID patients as compared to the controls. For people who are over the age of 65, all 26 of these conditions were more common in the post-COVID patients. 22 of the conditions were more common amongst those less than 65. The highest risk, as you can see, are in the pulmonary group. And then if you go down further, you can see some of the neurologic, and then the musculoskeletal symptoms are more common. But again, it's very consistent with the scope and breadth of the literature showing that post-COVID is alive and well and has real implications on our healthcare system and our ability to care for these patients. And COVID is going to continue to affect our population for years and years to come, as some of these people continue to have these conditions probably for the rest of their lives. You can see that this is the visual abstract that came out with the article, and I think is a very nice visual demonstration of the results from the study. As I've already mentioned, there's a number of limitations with this. It only goes up through the Delta wave, and so does not include the Omicron or the subvariants of Omicron. It's the Cerner database, which is not every American, but again, it's over 60 million Americans. It doesn't take into account some of the confounders that you would like to look at, so gender, race, ethnicity, region of the country, et cetera. It just lumps everybody together. It does rely upon clinicians using the ICD coding to describe these conditions, and any of those of you who have worked in EMRs and have coded records and applied these things know that providers are not imperfect as they go about doing their coding. And then there may be other conditions as well that simply haven't been defined as post-COVID. So they looked at 26 different conditions. They might not have captured the universe. Okay, so now moving into the next discussion that I wanted to briefly, and that is, does vaccination prevent long COVID? And should we be using that as a messaging tool for people as they make decisions of whether they should get vaccinated? This is another place where we just don't have enough data. There's lots of unknowns and remaining questions. The limitations of all the studies are that they use differing definitions of long COVID and the symptoms that are sought. They oftentimes use different ways of defining and finding patients that might have long COVID. Some of them have used direct patient interviews. Others, like the study that I just showed you, just used EMR and various types of coding. Different surveillance periods, anywhere from 1 month to 6 months or longer. Some generalizability issues. For instance, one of the studies that just came out and was heavily publicized came out of the VA system, showing not a great impact of vaccination. But on the other hand, again, it's a great population for studying older white guys, but not necessarily the rest of the US population. There's lack of subgroup analysis in most of the studies, and again, the effect of the variants is pretty much undefined. Having said that, I think this is, although getting a little bit old, was a really nice look at the available data that came out of the UK. And this looked at 15 different studies examining whether vaccination either pre-disease prevented long COVID, or whether after people had disease, whether vaccination would help to limit those ongoing symptoms. 6 of the 8 studies suggest that the vaccine before illness decreases the risk of long COVID in the 1 to 6 month observation period following the infection. And the overall conclusion from this, again, I think fairly comprehensive look at the data, through the end of 2021, said that there's evidence that vaccinated people who were subsequently infected with COVID-19 are less likely to report symptoms of long COVID than unvaccinated people in the short term, medium term, and long term. And this is in addition to any benefit that vaccination might have in preventing COVID altogether. So these are the studies that were looked at in this compilation. I'm not going to go through these in any great detail. You can see that the range of decreasing long COVID symptoms ranged anywhere from 13% in the VA study that I just mentioned, that again was just published in this last few weeks and got a fair amount of play in the literature, in the lay press. And then you can see the other studies seem to indicate a fairly substantial impact, usually around a 50% or so decrease in long COVID symptoms. The last study there showed that there wasn't any decrease in the composite scores, but there were decreases in specific symptoms. And then there was one study, the Argent study, third one listed there, actually showed that vaccinated people had more likely to develop COVID symptoms. I think that's largely due to the way that they were finding cases. These are the 8 studies with just a little bit more information. This will be in your slide set. I'm not going to go into this in any detail at this point. And then to bring it full circle, I just wanted to, again, emphasize, and I know that I'm preaching to the choir here, that vaccination continues to be our best tool to fight this pandemic, and that even now, after the Omicron peak, as we're getting into the subvariants of Omicron, you can still see an effect of vaccination, that if you're fully vaccinated, and again, using that term, which means that you've only completed your primary series and doesn't necessarily mean that you've been boosted. This is data from the New York Times showing that if you're fully vaccinated, you're twice as likely to develop disease if you're not vaccinated versus fully vaccinated. You're 8 times as likely to die if you're unvaccinated compared to those who are fully vaccinated. And then we've also seen this graph on this group before, showing the United States is just dismally failing in getting booster doses into our patients. When you look at really any of the countries in the developed world, and some that you wouldn't classify necessarily as having high resources, Chile, Brazil, etc. So we need to do a much better job in our country with getting people to accept the booster. Again, I think we can use long COVID as a messaging tool to relate to people that they will have a decreased risk of developing those symptoms if they get vaccinated. And then lastly, I would point out that today, most of you heard that the FDA committee will be considering Novavax, and we may be able to also use that to our advantage if, again, it gets FDA emergency use authorization, because it's a much more traditional approach to vaccination. So it's an adjuvanted protein. To the best of my knowledge, no fetal cells were involved in the development or testing of the vaccine. Therefore, that takes that off of the page for those people who have that religious objection. For those people who still think that somehow mRNA is an experimental approach, hopefully the traditional protein with an adjuvant will reassure them that this is an approach used for many of our vaccinations, and is a safe and proven way to go forward. So those people who are still, riding the fence a few of them may accept the Novavax if it does indeed get approved.